A very good morning to all of you. First of all, I would like to thank AIOCMTC Scientific Committee for giving me the opportunity to be part of this nice scientific fest and respected chair to present my showcase of work in front of the Doyen of Indian Doyens of Ophthalmology. So I'll be presenting extreme Phaco in compromised cornea. I have no financial interest. So basically, I'm the cornea surgeon. So those patients are sent to us. Somewhere it was not refused or not done for the Phaco, for the scar cornea. So how to proceed the things? From a cornea surgeon perspective, I'm presenting this. This is a video-based presentation. Please enjoy the video. Sound, please.
And surpasses by leaps and bounds techniques of
Sound, please.
the past decade. From dealing with mature white cataracts to hard rocky brown ones, surgeons of the day are confident in utilizing Phaco for incredible results.
But what happens if the patient comes with cataract lens with Fuchs endothelial dystrophy or a post-Moran's scarred cornea having gutter formation, or a cataract lens with vascular scarred cornea as a sequelae of the post-SJS, or old leukomatous scar with mature cataract?
In this presentation, I demonstrate the utility and outcome of phacoemulsification as an alternative route to appropriate management of compromised cornea. The prerequisites for performing Phaco in compromised eyes: no surface inflammation, moist eye, corrected tear film instability, IOP should be controlled, sound posterior segment, appropriate IOL power calculation, a rational surgical plan with minimum tissue handling, and a team approach. Let's walk through some surgical videos. This is a case of Phaco in nuclear sclerosis grade 4 in Fuchs endothelial dystrophy with centrally zero cells, which is clinically observed while staining the anterior lens capsule. We've performed Phaco in ozone dynamics under dispersive OVD coverage to protect the residual endothelial cells. We must keep in mind to do the Phaco in bag or in the iris plane, as this results in clear cornea with quiet eyes. The next case involves a post-Moran's patient having NS2 with posterior subcapsular cataract, peripheral gutter, thinning and scarring from 9 to 3 o'clock. As such, SICS or ECCE were not good options for this patient. Main wound of entry was made at an inferotemporal position, and Phaco was carried out in ozone dynamics by stop and chop technique. Don't hesitate to put a suture if corneal thinning is clinically noted in scarred cornea to get an amazing post-op. Let's move on to Phaco in vascularized scarred cornea, involving the visual axis as a sequel of Stevens-Johnson syndrome. Rexis done in retroillumination made the job a little easier. Phaco is carried out as usual using stop and chop technique. Followed again with retroillumination during cortical washing. The surgery was completed uneventfully despite poor visibility peroperatively, leading to a predictable outcome. Here we have another tricky situation with leukomatous corneal scar and white mature cataract. Rexis is really tricky here due to a corneal scar in front and intumescent white cataract, but we were able to complete the procedure with a slow and controlled approach. We had no optical keratoplasty tissue available due to the pandemic. The patient was in need of some ambulatory vision, due to the other eye having poor vision since childhood. Once the lens was emulsified, microscope was switched on to retroillumination mode, and the surgery was successfully performed, allowing the patient good ambulatory vision after the operation. Finally, we have another tricky case, with post-herpetic scarred eye and cataractus lens. Retroillumination is a good option, but it was not available on that day. So we used an external illuminator that was commonly utilized for IV cannulations in kids, and completed the surgery in a routine fashion.
So these are the literatures.
Certification is the current standard.
So take-home message is that we plan the things. Number one, surface should be quiet and appropriate IOL power calculation, and we should be pre-plan what I'm going to do on the day of the surgery for the respective each case or individuals, not a holistic approach. Yes, ma'am. Yes, ma'am.
Yeah. Thank you, Dr. John. I think it was a nice presentation. How would you decide when would you want to do just a cataract surgery Or when would you want to do a combined procedure? Would you do it a single stage or a sequential stage?
Yeah, yes, well, ma'am. Among them are except that white intumation one, that should be the clean cut case of the combined cases of the optical PK with the your cataract surgery. The last one, intumation one with dense rheumatoid scar one. So that patient came, ma'am, during the time of the first wave of pandemics, and she was totally patient came into us is a wheelchair bound patient, one-eyed patient. I supposed to the combined procedure. But on top that time, as the oculoplasty tissue, I mean the optical tissue was not available. So initially I planned for, I do the, at least for mobilize the patient, I am doing the cataract surgery. Later on I was planning for the optical PK. But when the tissue was available, then I offered the patient, should I go ahead with the optical one? She refused. You know, I am happy. And to be very honest, now she travel alone. Earlier she needs one attendant to come. So that is the specific clean cut case. At the other cases, like the Fuchs one, each case I discuss one by one. The first one, it is not that earlier when you do the fellowship that time, then if there is central gutter is there, you should jump for the combine the DESEC plus Phaco or DEMEC or Phaco. It's not like that. If the peripheral, you know, whenever as a corneal surgery perspective, we do the specular one pre-operatively. We usually check the peripheral, I mean the pool of the endothelial cell. If the peripheral pool of endothelial cells are good, and the central there is only decompensation, so directly we can go ahead with the simple clean cut Phaco without doing the second DEMEC, the first one. Second one, whatever I have done, ma'am, that is the Moran's one. You know, this is the only option the Phaco, because the superior part we can't do that SSS tunnel, because from the 2 o'clock to 10 o'clock there was the gutter was there, but patient was actually, I saw the refer patient for MMF, patient was an MMF, microphone mofetil. And when the eye was absolutely quiet for more than 6 months, then I go ahead with the procedure, and the only virgin part of the eye is the inferotemporal part. I was sitting literally inferotemporal part and doing the Phaco. So this case was simply the Phaco one. Another one, the SJS patient, ma'am, being a corneal surgeon, all of us know that if it is possible, you don't want to do the optical PK in the SJS patient, because we know there is an unpredictable outcome of the SJS one. So that patient also, some of the hospital, they have done the quiet eye, the other eye left behind. So I have done these things. Yes, ma'am. Yes, sir.
So I think the take-home message is that you would always want to tailor the ocular conditions of the patient, the diagnosis for which you are doing, how much of postoperative visual acuity you would be able to obtain by just doing a cataract surgery, and if it will suffice for the visual needs of the patient considering the age. And you would also probably look at the viability of the residual endothelium which is present here.
Exactly.
And if it's a post-viral etiology, then probably even an uneventful cataract surgery will result in a higher endothelial decompensation. Yeah. If you're looking at Fuchs, there is a fantastic latest tomography-based classification for the prophesizing those cases which would probably progress or not progress. So probably that approach would also help, and you really need not rush into a transplant for all cases.
Exactly. You should look for the peripheral part, because I have series of Fuchs patient. So as of now, last 3-4 years, they are following up. None of the patients showing the decompensation. Yes, sir. Yes, sir.
Vanati, is Ripatech help?
Sir, according to current evidences, Ripatech is not said to be very helpful in cases where you're having Fuchs here. Concept-wise, yes, it should, but I think even in the recent World Cornea Congress, people who have looked at it from what is available with us, and the current evidence does not show it to be really helpful.